or
Okay.
relevant to what we're talking about. Okay. All right.
Great.
We're live. Yay. Good
Woo.
morning, good afternoon, good evening, depending on when and where you're watching this Facebook Live. This is the voice and the face of Dr. Tolu Olabinton, CEO and co-founder of Living Spring Family Medical Center here in the amazing city of Mansfield, Texas. We believe in helping our patients live long and well, and that's why we're having these discussions, because we believe that your quality of life is just as important as your quantity of life. And I'm excited to be on this live talking with the one and the only Dr. Kerry Reller. Thank you so much for coming, Doc.
Hi. Thank you for having me.
Oh, awesome, awesome. Thank you for taking the time to come. I know you're busy, so I appreciate you taking this time out. For those of you who are watching live, hashtag live. For those who are watching the replay, hashtag replay. And today we'll be talking about asthma. And the topic is, Doc, I have asthma. Why do I need all these inhalers? Now, before we go ahead, I want to introduce our guest a little bit more. Okay, I want to talk a little bit about her. She's a board certified physician in family medicine and obesity medicine, and she practices in Clearwater, Florida. So if you know anyone who's there who needs a physician, you can look her up. Now, I just found this out actually, that before she went into medicine, she was an electrical engineer. And she completed her family medicine residency at the University of Maryland, and then she moved back to Florida to join her father. And she actually learned the clinical practices of allergy, asthma, and immunology. You're impressive, dog. Almost like you're gluten for punishment.
Yeah, I like a lot of learning in school. I keep going at it.
Wow. And you know what's really unique about her as well? She loves helping patients manage and prevent chronic disease by sustainable lifestyle improvements. So she's our gal. And so we appreciate you for coming. Thank you, thank you, thank you.
Thank you. Thank you for having me. I'm
All right,
excited.
now we've talked about you, what you do, and family medicine, allergy medicine. But here's the question, especially you transition from engineering to medicine. Why do you do what you do?
Why do I do what I do?
Yeah.
I like to help people. I like to help people in the community. I previously my role as an engineer, I didn't really get the chance to directly help anyone, and I think that kind of made me steer away from it.
Mm.
And I just like seeing the feedback from my patients, whether it's better asthma control, better
Mhm.
allergy control in this case. And then for my weight management program for the obesity medicine side, it's really rewarding to see people say, hey, my knees feel better, I'm breathing better, I'm moving better. And, that just makes me feel good inside. And I mean, that's my goal, to help them, live better and healthier, happier lives.
Awesome,
Mm-hmm.
awesome. And I bet you were helping people even as an engineer. You just didn't
Oh,
see it. So proof. But this I get it. I get it. I share those sentiments as well.
mm-hmm.
Now we're talking asthma today. Hi, Mitra. Thank you for joining. Um, what is asthma? For someone who's watching, like, yeah, I've heard. I have. Look, what is asthma? What would you say, Doc?
Yeah, so asthma, I think the definition has changed a little bit over the years, but the latest guidelines are saying that it's the symptomatic of wheezing, which is like that high pitched noise of expiratory breaths,
Mm-hmm.
and cough, um, shortness of breath, and chest tightness. And that's also characterized by the reversibility of obstruction in the airway. And then also further on, it's basically chronic inflammation in the airway and hyper responsiveness of the bronchioles, or those, tubes of the lungs.
Okay. All right. So
And then,
wheezing, cough, reversible, chest tightness.
mhm.
Um, awesome. Um, you're going to say something. Go ahead.
Yeah, I was going to say, so there's many different kinds of asthma, but most of all, they need like that reversibility component. However, it can be over the years kind of diminished. Like, so you don't, may not be reversible anymore. And we call that kind of airway remodeling. So usually you need that breathing test to confirm asthma. So that's that
Okay.
spirometry, where they make you blow really hard into like a tube in the office. And that will confirm whether the amount you breathe out in 1 second is reduced or not. And
Okay.
then we follow it up with like a albuterol or one of the inhalers that we're going to talk about that helps expand the lung and open that airway. And if it does that and you get a higher number on the breathing test, that kind of confirms that reversibility of obstruction. Yeah.
So the key word is it's reversible. And that's what
Right.
differentiates asthma from most other lung diseases.
Right. Exactly.
Now, my next question is this, and this is where, and I think you can relate to, we get this in conversation with patients where they're like, well, how many inhalers do I need? Like, why do I have this one, the red one, and I have this purple one? So generally speaking, and of course, I'm sure you can give examples, how many inhalers do I need if I have asthma? That's a patient asking.
Yeah, so it kind of depends on the severity of the asthma. So I can't really give a blanket answer for that question. And the guidelines have changed. So it used to be that you just needed, here, I'll show you. I brought them all. A one like this. This is called a short-acting bronchodilator, and it's albuterol. This is the Pro Air HFA. Can you see it?
Yeah.
So basically you push in right here, and then at the same time you're sucking in, so you have to like time it. And that's the one that we say you use as needed. Okay, so you would take 2 puffs every 4 to 6 hours if you're having that wheezing, coughing, shortness of breath, or chest tightness. Okay, so that's the that was the typical guidelines of just kind of starting with asthma. You need just this. But recently they have changed the guidelines where they, every time that you either take this, that they also want you to take an inhaled corticosteroid with it. So that would be something like Flovent or as any other fluticasone or anything like that. I have a bunch behind me. So that's to kind of reduce the inflammation at the same time that you're given that bronchodilation. So in the past, it was just this, but now they want you to do the inhaled corticosteroid with it. And then there's another option of doing that instead, and that's doing the inhaled corticosteroid with something we call a long-acting bronchodilator. And that's one like this. This is called Symbicort, and it has the corticosteroid and that long-acting bronchodilator. So that basically it's an albuterol that lasts longer. So they say as needed use of this is the new for those, they're called the GINA guidelines, which is the Global Initiative of Asthma in 2022. So they give you like 2 different tracks to really confuse you.
Right.
So this one, which has 2 medications in it as needed, or the typical one, which we did was the short acting with the inhaled corticosteroid as needed. So in our office, I will say we have not fully adopted those measures because it's a cost thing too, right? These inhalers are very expensive. It's the device design and everything. And they're not all, you got to figure out which one's covered by which insurance. It's really a headache sometimes. So we're using probably the most cost effective thing. If we had a sample to give everybody, then that would be easy, right? But if they're just using those inhalers as needed, it's hard for them to put out that extra money sometimes to get the ones that they need. So typically we still go with the traditional guideline, which is the short acting bronchodilator as needed. And then if the severity picks up, meaning that if they feel that they need it more than twice a week, then we're adding on a different inhaled corticosteroid. Right. And then if they're still not controlled at that, we step up therapy to a stronger inhaled corticosteroid with that long acting bronchodilator. So it might be something like this one. So these are kind of the same Symbicort asthma, but they're different devices.
Right.
So we try to stick to the same device style too of each patient. Right.
Okay.
So, and then from there, depending upon the severity, we keep increasing the inhaled corticosteroid strength. And then they even have a new guideline for asthma that used to be previously only COPD. And that's these long-acting muscarinic agents that can help also dilate the airway. And those can be found in these new medicines that are triple therapy. So 1 inhaler, 3 medicines, 1 copay. And that's this one. And there's another one, but it's not FDA approved for asthma. This one's FDA approved for asthma, and this is called Trelegy. So it has the inhaled corticosteroid, it has the long-acting bronchodilator, and it has that long-acting muscarinic agent in it as well. Mm-hmm. So it's very complicated in the inhaler world right now, and it keeps getting better and better for treatment of the patients, but the cost, because of new devices and new meds, is not really getting better. But in short answer, they need probably 1, 2, or 3 inhalers depending upon how severe their asthma is. And what's nice is the 3 might really be condensed into and just the short acting, to save on copays. Any other questions on?
No, that was a lot, and that was very good. And I have to say, I like your stepwise approach. So lowest, most effective inhaler, as necessary, and it's cost saving too. So I like that approach too. And one of the things I wanted us to clarify too is the as needed definition, because I think I have patients who come and say I use my Symbicort as needed, or I use my Advair as needed. Before I take the question that we have from a viewer, can you explain the as needed term? Because Buterol is as needed, but the other one is not quite as needed.
Well, right. So that's where it was getting confusing with the new guidelines too. Right. So the patient, in historical standpoint, they should be taking those Symbicort, the Advair, pretty much every day. So Symbicort is usually 2 puffs twice a day. That's maxed out on whatever inhaler they have. And as Advair, this one is 1 puff twice a day. Okay. So those historically should be used, every day. Do it, keep it with your toothbrush, brush your teeth after. That's usually what I tell the patient. So as needed approach is when you're having a little bit of exacerbation of your asthma. So maybe you're getting exposed to some of your triggers, like allergens, like pollen in the air, and you're feeling short of breath, wheezing, coughing, or you're feeling like your chest tight. So that is when you need it. So you would do 2 puffs of that as needed albuterol inhaler at that time. So we don't really want you using that unless you need it. And there's a good way to prove that you need it by using a peak flow meter prior to taking it. And a peak flow meter kind of does like a home breathing test at home. And it measures, how much lung function you have at that time. And it's a good measurement, but it's not gold standard, which is why it's just only good for home use, not for office use. But if you do that peak flow meter and you're at 60% of your best, you need that inhaler, right? You should go ahead and take it. That proves that you need it at that time. Because a lot of patients with anxiety may think that they need it, but they really don't until they prove it. So what was the question?
You answered the question about the as needed. Like, what is that? What's the definition? Because some people think using the Advair as needed is similar to how you use the albuterol. So it's very important to distinguish the two. The albuterol inhalers, you're supposed to use that as needed for wheezing or an exacerbation or a flare, but the other ones are usually preventive.
Right, exactly. Yes. Sorry, I didn't use the word preventive. Yes, it's preventative. It's meant to be used every day. So you do not need the other one. You do not have an exacerbation. You don't end up, coming in for more treatment or anything like that. So keep using it every day, keeps the inflammation of the lungs down, and you shouldn't have to need the albuterol is the goal. It should just be there and then it expires.
Right. And some people, they're like, well, what's the big deal? I use it. It works, Like, what's the big deal with albuterol? I tell them, the heart, can stress the heart unnecessarily. So we want to use that as little as possible. So that's a good one. Now, someone asked a question, says, can you outgrow childhood asthma? And what does that mean? What does it mean to outgrow the childhood asthma? What does that mean?
Yeah, you definitely. There's something we call like an atopic march. So when they're young, they may get like eczema, the itchy rash, and they may have some like what we call bronchiolitis or RSV, and that can eventually lead to we call reactive airway disease. And later on, when they're 5 and they can actually prove it on a breathing test, then it can lead to asthma. But they still have the potential of outgrowing it and not having any problems, the rest of their life, or they'll outgrow it for 20 something years. And then, maybe 20 more years down the road, they might actually have some problems. So it's true you can outgrow it, but it's also true it could be dormant for a while and come back. I guess it's always in your genetic tendency to have it.
And that's why it's very important to kind of reveal those kind of information. You had childhood asthma, so that way there's some kind of respiratory issue. It's like, oh, maybe there's a reactivation of asthma from childhood. So it's important to divulge your past medical history.
It is, yeah. Because sometimes we'll see that, like, okay, you had asthma, you didn't have any problem all this time, and then all of a sudden they have a problem. We do a breathing test, and it's way down. They may have something like airway remodeling, like I was describing, that, causes the breathing test to be lower, but they don't even know it. Like it's been kind of steadily happening over time without them knowing.
Right. All right. So I have someone who's asking, saying, Doc, thank you for the tips on the inhalers, the different types, why they're used, and the different options. But is there a way to help reduce how many I have to use? Because I don't like medicine.
Yeah. So the goal there would be to get rid of the triggers, right, of why you may have an asthma exacerbation. The most common trigger and the most common type of asthma is allergic asthma. So to treat the allergy component reduces the inflammation there. So we would do that by working you up, seeing if you have allergic asthma. So doing a skin test with the little pricks on your back and maybe in the arms for intradermals to not miss anything. And then evaluate whether this is contributing to your symptoms and putting you perhaps on a allergy immunotherapy program. So that they also have sublingual. We don't use that much in our office, but that is subcutaneous injections that you start, kind of coming in like twice a week for a while, and then goes to once a week. And then you can separate it all down to about once a month. And using that treatment can make you not need inhalers. Like if you have allergic asthma, it's the best way to not need inhalers as well. And then there are other things like same thing. This is for pollen allergy, cat allergy, dust mite allergy. Those kind of things can be treated with allergy immunotherapy. And then there are stronger medications, biologics, that can help get off inhalers. And then just overall, avoiding other triggers. So some people have cold weather triggers. You can move out of, move to Florida, right? That's where I am. Or they exercise can be a trigger. You can't really usually avoid using that short acting bronchodilator if you need it before exercise. Viruses are a trigger. So staying healthy, maybe you need to be worked up for immunodeficiency, and making sure that you're not getting, too many viruses or bacterial infections. So that's important too, to make sure your immune system is intact. But if that can sometimes end up reducing inhalers in the long run. And let's see, irritant exposure. So exposures to like perfumes, cleaning equipment, stuff. Yep. Obviously smoke, right? Those are things that avoiding that or stopping smoking can help also probably get off inhalers. Time, just maybe you're going to outgrow it. You may get off the inhalers. And then, like I said, using those combination inhalers. So you get reduced down to one inhaler instead of having 3 different ones. That can be another way to do that. Yeah.
All right, awesome. You've given us a wealth of information. And, of course, these are medical suggestions. We do encourage you to book an appointment with your primary care doctor, see your allergist, see your pulmonologist to discuss a plan that's well tailored for you. I have one more question before we round up. He said, my son has a nut allergy. Why are EpiPens so expensive? I hear this a lot. What would you say?
Yeah, there was like, I think maybe 3 or so years ago, I think the company Mylar was kind of cornering the market. And that is the one that makes the actual EpiPen. There is generic epinephrine in an EpiPen form that you can ask your provider to try to prescribe. And then there's also something called AviQ that is the one that talks to you. Um, and that one can be helpful for if anyone isn't, isn't confident in using the thing. It just talks to you and tells you how to do it. And that one just has to go to a specialty pharmacy, and usually it's pretty well covered even with refills. So there are ways around, getting the brand EpiPen. You just might need to ask. And it's and allergies and asthma is expensive treatment because the inhalers are constantly coming out new, and these things, the patents don't really run out. There are some generic inhalers now, and then there is generic epinephrine, in an EpiPen form. So that is good. The device, I can't speak to if it's as good or anything, but I mean, you could do that. And then if you have like a family member who is very good with needles and syringe, there's always that method too, but that's not really convenient when you're trying to stop a nut allergy problem. So I don't recommend that one.
Right. Yeah. So there are generic forms of the EpiPen that you can ask.
There are, yeah.
So that's awesome. That's awesome.
And the price did come down after that debacle.
Yeah, I saw it in the news. I think they were kind of criticizing them for, something so life-changing and obviously can be life-threatening if not available. Right. So I'm glad to hear that they brought the price down some. All right, Doc, thank you so much for this. This has been very, very, very informative. Now I have people who are watching who are saying, I like Dr. Kerry Reller. Sorry.
Everybody does it every time. It's okay. I don't worry about it.
Kerry Reller. Now, so someone's asking, where can I connect with this doctor? I'd like to come speak on my platform. I know people in Florida that could use her care. Doc, where can people find you?
Sure. I'm on Instagram at Clearwater Family Medicine and Facebook at Clearwater Family Medicine and Allergy. And then our website is www.cfma.health. Yeah. And we'd love to have you.
Yeah. I like that. .health. No org, no problem. .health. That's what we're about. .health. I like it. So we're gonna put all of that at the end of the live or by the end of the live, so that way people can connect with you directly. But I really appreciate you for taking the time to do this. I hope to have you again on maybe in a couple of months, so we could do maybe a second discussion on this as a reminder.
Sounds good. Yeah. Thank you so much for having me. It was fun.
My pleasure. My pleasure. All right. Thank you all for watching. Please, as always, caring is sharing. So forward this, share this, copy the link, post to those who could find this useful. And if you or anyone you know is looking for an awesome, a passionate, and a thorough family physician in the Mansfield, Texas area who have conversations to help you live long and well, I am she. Have a good one, guys and ladies. Bye.